So next we have Dr. Harshul Tak. He's a prolific phaco-refractive surgeon from Rajasthan, and he'll be talking on microkeratome LASIK, basic and role in 2024. All to you, Harshul.
Thank you so much, Dr. Sonu and entire AI scientific committee for giving this opportunity. I'll be speaking on microkeratome LASIK basics and relevance in 2024. So if anybody is thinking that what is the scope of microkeratome, let me tell you the industry forecast that by 2030, the microkeratome market size will be $1.3 billion. I can't make out how many Indian rupees is that. So there's a huge market. We all know that 70% of the surgeons, they are still using microkeratome LASIK, and recent Cochrane review in 2020 found there's no difference in visual acuity outcomes between femtosecond laser and microkeratome LASIK. So quickly going through the history, we all know it was Jose Bereker in 1958 who started keratomyelitis, and in 62 he developed manual microkeratome. It was Trokel and Srinivasan in 1983 who they found out the corneal application of excimer laser. And finally in 1990, Pellicaris who started using the hinge technique in LASIK. So as Dr. Rajesh said, that from the older time, the microkeratomes have advanced, and now we have advanced microkeratomes. And so the basic principle of all the microkeratomes, whatever company microkeratome we use, that there's a high precision oscillating blade system which is there. And this system, it docks to a suction ring, and which creates then it creates a lamellar corneal flap in the cornea. So basically microkeratomes, they either use a translational motion system, like in SBK, Moria SBK or Amadeus, where we create a nasal hinge, or we can use a rotational type of system like Hansatome, where a superior hinge is created, or either a nasal hinge can be created. So quickly looking at the component, so can I have a pointer please here? So we have a console here, so which is the central unit, and so there is a motor and microkeratome head, and there is a suction ring which fixates the eye. So there is a suctioning, and we have foot switch so that we can create the vacuum and we can progress the motor forward for the pass. So this is the central unit which delivers the energy needed to drive the motor of the microkeratome, as well as its suction ring is connected here, suction tubing, so that when we need to fixate the globe, it creates the suction. So, and this is the drive unit which is there in this, this is a Moria microkeratome. And this is the microkeratome cutting head. So now all these keratomes, they have disposable, these cutting heads here. So this is the non-vibrating block here, and there is a oscillating blade. So it is basically based on the principle of Carpenter-Rando, that when it moves forward, it creates a lamellar flap in the cornea. And there is a suction ring, which is via silicon tubing, it's connected to the central console. So the sizing and the stop of the suction ring depends on the horizontal keratometry of the eye, and we should always strictly use the nomogram given by the manufacturer. So this is the nomogram. I use Moria SBK microkeratome. So this is the nomogram which is given by the manufacturer. That I give you an example that if you have a K of 43, so if you have a horizontal keratometry of 43, we have to use ring of size 1, and stop is decided depending on whatever stop is given, 7.5. So if you have a diameter of the cornea which is greater than 12 millimeter, it's a larger diameter cornea, we need to use a ring which is a smaller value, that is ring 0, which is thinner. And if the diameter of the cornea is less than 12 millimeters, we have to use ring which is 2. That's the upper higher ring we need to use. So which is, all these things are given in this nomogram. We should always follow this nomogram, and we should always center the suction ring on the limbus. Don't try to decenter the suction ring. So after that, as I said, there are two types of systems. This is the Amadeus and the SBK Moria system, which makes a linear flap. So advantage in this kind of system is that when the flap is making, you can clearly see the flap which is being made here. So in cases, if you have a flat keratometry readings, if there are chances of free cap, you can easily see that yes, you have an entire flap in near the blade, and you can safely preserve that flap, and after ablation you can place it again. Whereas in the rotatory system like Hansatom, you can't really see that what's happening down below. So this is the Hansatom or Carazo-pendular keratome. So as I said that nowadays almost everybody has moved to the SBK microkeratome, that is a thinner flap LASIK. So the advantage of this is that the flap which is made is around 100 micron thick, and so if we have a thinner flap, it preserves the biomechanical strength of the cornea, so decreasing the risk for corneal ectasia. And refractive and visual outcome SBK are also found to be comparable to or better than standard LASIK, because there is a faster visual recovery, better predictability, better contrast sensitivity, and lower rate of enhancement. And moreover, because of the thinner flap, we can get the more amount of myopia which can be treated. So advantages, as I said, of microkeratome is that its operation, it only takes 20 to 30 seconds as compared to femtosecond laser, which takes longer time. And because the operation time is short, suction duration is short, it allows patient to be more comfortable. And moreover, microkeratome LASIK, it causes less inflammation as compared to femtosecond laser. Chances of DELC are less in microkeratome. And it, of course, costs much less than femtosecond laser. So this is a study which compared the older generation microkeratome, Moria M2 microkeratome, with the SBK and the femtosecond laser. And this study found out that the flap thickness was more predictable in SBK and femtosecond group, with insignificant difference between intended and achieved flap thickness, whereas in the older generation of microkeratome, the difference is higher and statistically significant. If you look at the, so there are some complications, of course, which can happen with microkeratome LASIK, but if you look at the statistics, it's only 0.6%, with femtosecond it's 0.3%. So most common complication is the epithelial defect, which is caused by the shearing force. And there are other complications like free cap, buttonhole, which Dr. Rajesh mentioned about these complications. So I'll quickly show a short video of this. So it's very important to put the marks which are asymmetrical. So here I place 2 marks here and 1 mark here. In case you have a free cap, you can easily align the flap to these marks. So after that, you just put this suction ring there and build the suction. So suction has to build more than 65 millimeter mercury. So there are few clues which tells you that adequate suction has been achieved. First is, of course, pupil transiently dilates. Secondly, patient sees the light getting dimmer. And third, you can always check it with the intraoperative, this Barricade tonometer. So this is the flap which is made with 1 pass. As you can see, the flap here. And once you remove this suction ring, just 30 seconds more. So you just lift the flap, and after that, you do the stromal ablation. And once the stromal ablation is done, you just deposit back the flap. And you just let it dry for 1 to 2 minutes, and once it's dried, the case is over. So we have advantages with microkeratome LASIK, that it has a proven record. There is lesser cost of surgery, reduced surgical time, less inflammation, and can create flap in antecorneal opacity or scars also. Thank you very much.
Thank you, Dr. Harshul, for presenting something which large majority of people are doing. And yes, microkeratome is very useful. Only in very steep or flat corneas, there may be some risk. And the only minus point is that, I mean, it is not under direct visualization as you can do in femtosecond. But otherwise, it does its work in almost, I mean, large majority.
But with SBK,
with
Moria
almost
keratome,
similar
yeah.
efficacy. Yeah, yeah. Thank you. Yes, Vanashri.
So I have a doubt, like to all the panelists. If we have both the platforms available, I have microkeratome as well and a femtosecond laser as well, and if the cornea is steep, at what level should we take a cutoff? Like, and if it is beyond 45 or 46 cornea, should we prefer femto instead of MP?
Yes.
What should be the cutoff for a surgeon that you should think?
Anything which is steeper than the normal. I mean, if you consider, 42.5 and 43.5 as normal, and say, suppose it's more than 44. I mean, if you have the femtosecond laser, why don't you use femtosecond laser?
So
I have done
sometimes-
till, I do till 48 microkeratome LASIK without any problem.
Actually,
and in
above-
flatter side, 40, 39 also
actually,
I've done. But free cap is not a major problem. Of course, the steeper corneas, buttonhole is of course a problem.
So
but
sometimes the cost is an issue, like
More,
patients are.
Then more than 46 is my criteria. I keep that if it's, I mean, we have switched over completely to femtosecond, but when it was both, we were doing both, then my criteria is more than 46. Would like to have opinion of panelists that if it's more than 46, I would prefer a femtosecond laser rather than microkeratome because of the risk of flap buttonhole.
I do up to 48 also.
Yeah,
I got a old microkeratome from Amadeus 2. Actually, it works on the keratometry reading, and depending upon that, we can adjust the hinge. But that microkeratome last 10 years is not available in the international market. With that, according to them, you can go up to 48, 49 also. I have done, and I never faced any buttonhole.
No, the question is not that whether you do or not. The point is that whether there is any risk of flap buttonhole or not. That is the point. So, I mean, it is doable,
with,
but the risk is there.
with
feel,
SBK
40
microkeratome, I still do till 48. I didn't have any of
I
the flap
feel for
complications.
the sake of the the audience, 46 should, for me and most of us, 46 should be the line. Yeah, because we can do many things, but there are certain stunts which cannot be tried at a general level. So please, I think 46 should be a
I
safe.
think most of us now shifted to femto only.
Yeah.
So question